You're listening to Medscape's In Discussion series on breast cancer and HER2, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Kathy Miller, Valve Lentero Professor at the Indiana University School of Medicine, Department of Medicine, Hematology Oncology Division. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hi, I'm Dr. Kathy Miller. Welcome to the Medscape In Discussion podcast series on breast cancer and HER2. Today we're going to talk about pulmonary toxicity from the antibody drug conjugates. So first, let me introduce my guest, Dr. Erika Hamilton. Dr. Hamilton is a board-certified medical oncologist and the director of breast cancer research and the chair of the Breast Executive Committee at the Sarah Cannon Research Institute. Welcome to Medscape In Discussion Breast Cancer and HER2 podcast.
I am so happy to join you today. Thanks for having me.
So first, Dr. Hamilton, let's talk about the scope of the problem here. How frequently is interstitial lung disease with the antibody drug conjugates?
Yeah, that's a fantastic question. And really, I think we started talking a lot more about ILD with trastuzumab deruxtecan. From different studies, we see this range somewhere between about 10% and 15% all grade ILD. And this is higher than we see with other antibody drug conjugates, even other HER2 targeting antibody drug conjugates like TDM1.
So I'm going to put you in the Wayback Machine because when this was first reported with trastuzumab deruxtecan, there were a lot of folks who I felt like behaved as if ILD was a completely new thing that we had never seen with any agents before. It's been reported with, I'll call them now naked chemotherapies, unchaperoned chemotherapies. It was a big issue when gemcitabine was a new drug. It's been reported with cyclophosphamide, the taxanes. I remember when it was first reported with just plain old trastuzumab.
CDK4/6 inhibitors?
Yes. Is this really more common, or have we just become hypersensitive to it?
Yeah, it's a good point. I think the past few years, it has been a little bit difficult to tease out because we've also had respiratory viruses like COVID, et cetera, that can cause patchy infiltrates on a CT scan. It is interesting. I think with trastuzumab deruxtecan, I do believe that it is a little bit higher. I think that education really relies on recognizing it early because we do treat it a bit different than we treat ILD or pneumonitis from a checkpoint inhibitor, for example, where we really don't do anything if we see grade 1 ILD. So I think that's why it has gotten a lot of attention and kind of necessitates some education.
So let's talk about the presenting symptoms, because not only is education of the oncologists and their APPs and nurses important, those people need to educate our patients as to symptoms that they should be reporting. So what do you tell your patients about this toxicity?
Yeah, I think that's such a good point because the reality is somebody with a little bit of shortness of breath or a cough probably isn't even going to relate that to oncology. They're going to go to a walk-in clinic or they're going to go to a CBS walk-in clinic or something like that, their primary care physician. And so they need to recognize that if they're having any pulmonary symptoms, we want to know. So this can be shortness of breath. This can be a difference in activity before you're short of breath. This can be a resting cough, common things that you would think about as pulmonary complaints. And things that we can get confused with bronchitis, especially in our older patients, not having fever, et cetera, like you would expect with pneumonia.
So how do you balance that at this time of year? I know you have a really large group of patients who are fortunate to be in your care. There are innumerable respiratory viruses floating around. We're all inside in the holiday gatherings, hugging and clinking glasses and moving those viruses around. How is your phone not just ringing off the hook?
I think that's a valid question. Honestly, I feel like maybe we went really, really far and now we've scaled back just a little bit in terms of kind of ILD. I tell my patients that I want to know if they're having any pulmonary symptoms or any change in the activities they can do, any change in cough. Most of the time when a patient calls in, you can tease it out. I started to have a runny nose. I had a fever that day. Now I have a little bit of cough 2 days later. I find it's the cases where they're calling in with a pulmonary complaint and really haven't described being sick otherwise. Those are the ones that I'm thinking about for ILD. And I did have one case, gosh, I think this was about 5 years back that really shaped how I think about these. I had a patient that was on a phase 1 clinical trial, and it was actually trastuzumab deruxtecan in combination with the checkpoint inhibitor on a clinical trial. And she had just had scans 3 weeks before, and she was in the office, and I did the routine, "Are you having any pulmonary symptoms?" And she said, "Well, yeah, a little bit. I'm more short of breath when I carry the laundry up the stairs." And I thought, "Me too." I'm short of breath when I carry the laundry up the stairs. And she had just had scans. But, again, it was in combination with a checkpoint inhibitor. I said, okay, we ordered another scan and she had ILD completely new from 3 weeks before. She ending up having grade 3 ILD. She was briefly hospitalized. She was on a several month-long taper. And that is my only case of grade 3 ILD that I've seen, knock on wood, with trastuzumab deruxtecan. It also was not in the first year for treatment. So I feel like this case really, pokes some holes in what I thought and what I would have expected to pick up ILD. And so I prefer my patients to call than not call and leave responsibility up to me of whether I need to be worried about it.
So I actually tell them similar things. I tell them that their job is to just report and do the data dump. Context and figuring out what meaning things have. That's my job. I can't do my job if they're holding things back and not reporting everything they're noticing. There are some surveillance recommendations to look for ILD, even in patients who have absolutely no symptoms. So I have two questions for you. First, remind us, what are those surveillance recommendations? And then in our little bubble shared only with you and me and the people listening to this podcast, do you actually follow them? Because I'll tell you, I don't.
I will tell you what I do. I think the scans for staging, we're repeating those anyway. What my intervention is that despite the fact that sometimes patients can be on these therapies for a long time, and I would really start spacing their scans out, I tend to not do that with trastuzumab deruxtecan when I'm worried about ILD. So I tend to keep their scans every 9 weeks or every 3 cycles. There are some centers in the United States that are doing it every 6 weeks. I think that is very hard with commercial insurance. I don't do that, but I do tend to keep them every 9 weeks. And again, I'm also making sure that I get that pulse ox when they're in clinic, making sure that I don't pick up anything on pulse ox. But I'll be honest, I really have not found problems on pulse ox. It's more patient symptoms have been coming to me more frequently.
I'll admit I don't do it even every 9 weeks. I am very vigilant for symptoms. My threshold for hearing symptoms and wanting to investigate symptoms is very different with trastuzumab deruxtecan than it is with some other agents, just because the incident is higher. But I have some patients who are on these therapies for years. I just can't stomach exposing them to scans that frequently when they are perfectly well.
I completely hear you.
People have now heard me say I ignore those guidelines. But you can only do that if you are really vigilant in asking patients about symptoms, and your threshold for investigating minor symptoms has to be set pretty low. So if you find ILD, I will call this real ILD, not something that is just a centimeter of fluffiness on a CT scan in somebody who's running marathons and has no symptoms, but ILD that at least has some symptoms, but hopefully not severe. What do you do about it?
Yeah, so I think the most important thing is do not give any more of the offending drug. Immediately start steroids. I tend to have a low threshold to start steroids, even in some of those cases that really aren't symptomatic. The grade 1 ILD that you find. I tend to start steroids, get rid of it, and get them back on treatment. So I think that steroids have been very effective. The cases that I've really heard from the community where patients have gotten into trouble was there was a lack of recognition up front and they didn't get steroids early enough. If I have any questions about, is this really infection? Gosh, this looks a little funny on the scan. I involve my pulmonary colleagues. I'll admit I don't involve my pulmonary colleagues on all of these cases. I feel pretty comfortable handling many of them, but I think that that is a good tool we have. A bronchoscopy, ruling out other causes can be very helpful for those patients as well.
I think I have similar experience. I don't call pulmonology unless I really think this patient needs a bronchoscopy. I caused it. I know how to manage it. I can take care of this. Whenever we tell folks start steroids, somebody's going to ask you how much for how long.
Yeah, so I start 1 mg per kg initially. Now, if somebody's coming in and they're hospitalized and they're really sick, certainly go higher, right? But I'm talking about, outpatient, not a sick person with hypoxia. I start 1 mg per kg. I typically do at least 5 days, if not 7 up front. And then I think the key is the taper. This isn't something where you could do a Medrol dose pack and be done. You have to do a little bit of a longer taper to get them off the steroid.
So, tapering over how long is your goal? Realizing if you see recurrent symptoms or things starting to flare back up, you may have to revert to higher doses or go more slowly. But if all goes well, they start at 1 mg per kg. How long till they're off?
Is this where I tell you the art of medicine that it's not always the same for
Yeah.
each patient that I prescribe it to? I would say not very worried. I'm trying to get them off within 3 weeks. Other times I'm thinking more about 4 weeks.
So, in the meantime, Mrs. Jones, who's got metastatic disease, was doing really well on this therapy. Her disease is under control. She's now equal parts terrified and mad at you that you held the therapy that's working for you. And she's itching to get on something or get back on something. Do you slip in a dose of plain old trastuzumab in there while you're playing this steroid game, or do you just sit tight?
I sit tight. I have not gotten in trouble with anyone progressing, again, knock on wood, while I'm holding trastuzumab deruxtecan. I think the advantage is this is a highly active agent. I don't think short holds are going to affect patients' outcome. So I really resist doing that. I'm curious to see whether you do.
I haven't for the same reason. I have to go back and get the insurance approval. By the time I get that, it's another week or two down the road. And my hope is to get them back where they need to be in a time frame that really, in my mind, doesn't make sense.
I get that. I'll tell you the patient case that I was telling you about, my patient that had grade 3 ILD. This was actually a patient that I shared with Dan Hayes, a former ASCO president that I was treating on a phase 1 trial. But she subsequently went back to him and she had a relapse of her ILD. I briefly had to go back on steroids one time. But despite the fact she'd been on for about 15 months when that happened, she stopped it and she remained progression free for almost a year off treatment. So very interesting, even though she was very heavily pretreated, more than 10 priors. So I'm not too worried about a couple weeks off is the moral of the story.
I'm not either. And honestly, I would tell my patients that if missing one dose means your disease was progressing, we really were at the end of the usefulness of that agent for you anyhow. And it's time for us to move on. The other question that comes up is you found the ILD, you've treated it, it's responded, they're off steroids. Is it safe to rechallenge, to put them back on it? And is there a higher likelihood of recurrent ILD if you put them back on it?
So, yes and yes. It is safe to put them back on it if they had grade 1 ILD. There was a relatively nice study that looked at some of these patients. Patients did successfully go back on. Some patients did have ILD again. It was more than the 10 to 15% of the initial incidence. They did not appear to have more severe ILD. So it's not, a sensitization where if you have it once and it comes back, those cases are more likely to be fatal or something. The current recommendation is that if it's grade 2 ILD or greater, you should not retreat. I think sometimes that's tough.
Grade 2 ILD is any symptoms.
I know. I think that all grade 2s are not created equal. Grade 2 really is a pretty big bucket. Somebody that complained of a tiny bit of cough and somebody who was hypoxic but maybe didn't need to be admitted to the hospital is all within grade 2. So, have I re-challenged some patients with grade 2 ILD? I have. They have been the patients that were not hypoxic, but did have symptoms. They were the patients that had metastatic cancer and very well understood the risk of going back on trastuzumab deruxtecan, but also very well understood the benefit that this drug provided for them over, potentially a very long PFS. And with a educated, informed decision, they decided to do that. Luckily, I have not had any of those patients get into trouble. I'm not advocating routinely. Dr. Hamilton said all grade 2 cases of ILD can be rechallenged safely. But I do think that this is where the art of medicine comes in and really a conversation with the patient in front of you.
I said I don't follow the guidelines, so you can say it's okay to re-challenge grade 2, even though the guidelines said not to do it.
Valid, valid.
So, two other things in our last few minutes that I want to pick your brain on. The ILD was first reported in studies of people with metastatic disease. Many, though not all of those patients, had pulmonary metastasis. We are now using this ADC in patients without metastatic disease, either in a post neoadjuvant setting or in a neoadjuvant setting. Do we know yet? Is the risk of ILD similar in patients who don't have active metastatic disease, particularly who don't have pulmonary metastasis?
Well, this is a fantastic forward thinking question. You're right. We've had recent data from DB11 in the neoadjuvant setting, as well as DB05 in the adjuvant setting for trastuzumab deruxtecan. In DB11, let's start there. In the neoadjuvant setting, the risk of ILD was markedly less, about 5%. And remember, it was only 4 cycles of trastuzumab deruxtecan, so it was a shorter duration. Contrast that to DB05, we were getting 14 cycles of trastuzumab deruxtecan. Yes, the incidence there appeared similar to what we've seen, that right over 10% window. Both of these studies in the clinical trial were doing asymptomatic CT scans of the lungs to look for ILD. Do I think that I'm going to do this in the neoadjuvant for 4 cycles? No. Do I think we probably are going to be doing it in the adjuvant setting per guidelines because it's 14 cycles and the cumulative risk is higher? I do. I don't know where I'm going to settle out of how frequently I'm going to do it, but there is a component of the risk benefit ratio being skewed for somebody with curative breast cancer.
It's a much trickier balance because you also don't have any way in that adjuvant setting to know, is she benefiting? Whereas in the neoadjuvant setting, in the metastatic setting, you have disease present. You can see if she's responding, how well she's responding. You have both sides of the risk benefit equation to evaluate at that personal level. Whereas in the adjuvant setting, you are blind to the benefit. You have the population based benefit, but you don't have any individual assessment of benefit to guide you.
Absolutely.
So, one last question for you. Do we understand anything about who is at greater risk of ILD other than you're getting treated with these drugs? Is it folks who have pre existing COPD, the smokers, the diabetics, the older people, any of the usual suspects? Help us to know who we should worry about.
Wouldn't it be easy if we could predict who these patients were? I think we've gone around and around of this. They looked at patients in Asia versus patients that weren't in Asia. They looked at smokers. There was some look, particularly in the lung cancer patients. I think they have higher ILD, but they also have lung pathology. We aren't good at predicting who these patients are. It's not recommended that we have some type of test like a PFT or something that we can say, oh, this patient's at higher risk, this patient isn't. So it's not that simple. You cannot tell just by looking at the healthy patient sitting in the examination room across from you that they're not going to be at risk for ILD.
Well, that was profoundly disappointing as a way to end.
Sorry.
Not your fault. But it does make me think somebody with an interest in pharmacogenomics needs to dig into that and see if they might find something for us.
Absolutely.
So today I've been talking with Dr. Erika Hamilton about interstitial lung disease associated with the antibody drug conjugates, particularly brought to our attention with trastuzumab deruxtecan. We've talked about presenting symptoms, being particularly vigilant for your patients for cough, for decreased exercise tolerance, or increased shortness of breath, asking them those specific questions at each visit, paying attention to the CT reports and small interstitial infiltrates involving pulmonary colleagues when there might be questions of viral infections or progression of pre-existing pulmonary metastasis, because ILD looks for all the world like lymphangitic disease on the CT scan. So there are those times when a bronchoscopy and assessment can be helpful. Early recommendations to treat patients with steroids to get their ILD under control, both to prevent them developing severe, potentially life-threatening symptoms, as well as to then be able to get them back on treatment. Continuing to be vigilant for those patients who are resuming therapy. And unfortunately, no other predictors at this point to guide us as to who's at greater risk. So this is something that we'll need to pay attention to for all of our patients treated with these drugs. To our listeners, thank you for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on breast cancer and HER2. Dr. Hamilton, thank you for sharing your expertise with us today.
Thanks so much for having me.
This is Dr. Kathy Miller for the Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Breast Cancer and HER2 podcast series with our host, Dr. Kathy Miller. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on breast cancer and HER2.